Welcome back to Uncovering Bailey and Love. Today we're taking a deep dive into something that I'm sure we've all seen a lot of in breast clinics, nostalgia.
Yeah, for sure. Breast pain,
Yeah.
it's so common. And I think really understanding nostalgia, getting into the nuances of it can make a huge difference in how we manage it and how we reassure our patients.
Definitely. And it really is one of the most common reasons people come into the breast clinic.
Right. It is.
Mm.
It's estimated that between 50 and 70% of women who come to a breast clinic are going to be complaining of some degree of nostalgia. So, it's important for us as surgeons, especially those of us who specialize in breast surgery, to really have a clear framework for how to approach this and for how to understand, the different types of nostalgia and the different ways that we classify nostalgia, specifically cyclical versus non-cyclical pain.
Okay, so let's just jump right in then. Let's start with cyclical nostalgia. So when a patient comes in and they're telling you about their pain, what are some of the clues in their history, particularly when they talk about the timing of the pain, that would make you think, okay, this sounds like cyclical nostalgia?
Well, one of the biggest clues is when they describe the timing of the pain in relation to their menstrual cycle. So usually the pain's going to start kind of gradually around day 14 of the cycle. And then it slowly intensifies over the next couple of weeks. And it's going to peak right before their period starts, like around day 27, 28. And then the real giveaway is that it usually resolves quite quickly once their period starts, usually by day 1 of their next cycle.
So that predictable pattern really is kind of the hallmark of cyclical nostalgia. It
Right.
comes and goes with their cycle.
Exactly. And that's something that I always try to emphasize to the residents and the fellows. When you're taking a history, really paying attention to the timing of the pain.
Now, besides the timing, what about the characteristics of the pain? How would patients typically describe cyclical nostalgia?
Yeah, so usually the pain's going to be bilateral, so it's affecting both breasts.
Yeah.
And the intensity can vary. Some women will just have kind of mild discomfort. It might not really affect their daily lives too much. But other women have really severe pain that can actually keep them up at night. It can affect their ability to do their normal activities. It can even affect their sexual function.
Wow, so it can be quite debilitating in some cases.
Yeah, absolutely. And it's something that we definitely want to address, if it's impacting their quality of life. It's also worth noting that sometimes the pain can radiate to the upper arm.
Oh, that's interesting. So you can see how that might cause some anxiety, patients thinking that maybe it's their heart or something.
Exactly. And, it's important to take that seriously to rule out any cardiac causes. But in many cases, that pain radiating to the arm is actually coming from cyclical nostalgia.
Now, when it comes to the cause of cyclical nostalgia, what are the common theories that people have? And what does Bailey and Love have to say about that?
Yeah. Well, there are a lot of theories out there about what causes cyclical nostalgia. I mean, people have attributed it to hormonal imbalances, too much caffeine, not enough essential fatty acids in their diet, water retention. Some people even think that, psychoneurosis could be a factor. But the reality is that research really hasn't found strong support for any of these as a direct cause of cyclical nostalgia.
So even though patients might think, oh, maybe it's the coffee I'm drinking, or maybe it's because I'm stressed out, there's not really good evidence to support those ideas.
Right. And what's really interesting is that when we look at women with cyclical nostalgia, their basal levels of estrogen and progesterone and prolactin are usually normal. So it's not that they have unusually high levels of these hormones. It's more likely that their breast tissue is just extra sensitive to those normal hormonal fluctuations that are happening throughout the menstrual cycle.
Okay, so their bodies are essentially reacting more strongly to normal levels of hormones. Interesting.
Yeah. And this is where treatment comes in, right? Because if we think that it's this increased sensitivity to estrogen, then it makes sense that anti-estrogen medications can be helpful. And in fact, that's what we see. Medications like tamoxifen or meloxifene or danazol, these anti-estrogen medications, they can actually provide pretty good relief for many women with cyclical nostalgia.
So it's not necessarily about correcting an imbalance, it's more about dampening down that tissue response.
All right.
That makes sense. Now let's move on to non-cyclical nostalgia. So how does non-cyclical nostalgia differ from cyclical nostalgia in terms of its presentation?
Well, the big difference is that non-cyclical nostalgia doesn't have that clear relationship to the menstrual cycle. So women with non-cyclical pain, they might have pain at any point during their cycle. They might have pain even after menopause. So there's no predictable pattern.
So it's much less predictable. And what about the characteristics of the pain itself? Is there anything specific about non-cyclical pain that might help us distinguish it?
Yeah. Often non-cyclical pain is going to be more localized. So
Yeah.
instead of that sort of diffuse bilateral pain that you often see with cyclical mastalgia, women with non-cyclical pain may be able to point to a specific area where it hurts. They might even have a trigger point, a specific spot that when you press on it, it reproduces the pain.
So that really points to a different set of potential causes then, right? Because it's not that kind of widespread hormonal response that we're seeing with cyclical pain.
Right, exactly. So when we're thinking about non-cyclical nostalgia, we need to consider a broader range of possibilities. So Bailey and Love talks about a few potential culprits here. They mention things like duct ectasia, which is a condition where the milk ducts become dilated and inflamed, periductal mastitis, where there's inflammation around the milk ducts.
Hmm.
And then there are musculoskeletal causes too, things like Pizzi's syndrome, which is an inflammation of the costochondral junctions.
So the joints where the ribs attach to the breastbone.
Yeah, exactly. Trauma can also be a factor, even if it was a minor injury that the patient doesn't really remember.
So we really need to think outside the breast itself, too.
Absolutely. We have to consider things like chest wall pain, costochondritis, pain coming from the ribs, and even things like angina or biliary colic or reflux esophagitis. We even have to think about cervical spondylosis, which is a problem in the neck that can sometimes cause pain to radiate to the chest.
So it's like a much longer list of potential culprits for non-cyclical mastalgia.
Yeah. And then, we also can't forget about less common possibilities like sclerosing adenosis, which is a benign breast condition. And of course, although it's rare, we always have to keep malignancy in mind too, even though pain is only the presenting symptom in about 5% of breast cancers.
Right. And even though that percentage is small, it's always something that we have to consider. So it sounds like with non-cyclical mastalgia, the key is really to be very thorough in our workup to make sure we're not missing anything.
Exactly. So, when a patient comes to my clinic with breast pain, I start with a very detailed history. I want to know everything about the pain. Where is it? When did it start? How long does it last? What makes it better? What makes it worse? Is it related to their menstrual cycle?
So really getting a clear picture of the pain pattern.
Yeah. And then, of course, a thorough breast exam is essential. We're looking for any lumps, any skin changes, nipple discharge. And then, depending on the patient's age and what we're finding on the exam, we might order imaging. So a mammogram, an ultrasound, sometimes both. And a lot of times just having that normal mammogram and ultrasound can be really reassuring for patients.
Yes, definitely. Reassurance is so important. Now, Bailey and Love emphasizes the value of having patients keep a pain diary. How do you use that in your practice?
Oh, pain diaries are super helpful. I ask my patients to keep track of their pain for at least a month, ideally 2 or 3 months, and they can just write down, how bad the pain is each day and when it occurs. And this can really help us to distinguish between cyclical and non-cyclical pain.
So we can actually see those patterns emerge over time.
Right. And sometimes, a patient might think that their pain is related to their cycle, but when you actually look at the pain diary, it's not so clear. So it's a very valuable tool.
And for those patients who do have non-cyclical pain, what are some specific things that you're looking for during your exam?
Well, with non-cyclical pain, I'm always paying close attention to the musculoskeletal system. So I'm feeling the chest wall, the ribs, the costochondral junctions, looking for any areas of tenderness. And I'm specifically trying to see if I can reproduce the patient's pain by pressing on these areas. If you can, then that's a pretty good indication that the pain is coming from a musculoskeletal source.
So really trying to pinpoint the origin of the pain.
Yeah. And if a patient has a very localized area of tenderness, I'll try to see if there's a trigger point. So that's like a really specific spot that when you press on it, it triggers the pain. And if we can find a trigger point, then that opens up the possibility of doing a trigger point injection.
All right, let's talk about treatment. So aside from ruling out anything serious and providing reassurance, what are some of the first-line measures that you recommend for mastalgia?
One of the simplest things that can make a big difference is making sure that the patient is wearing a supportive bra. So I'll often recommend a sports bra, especially during exercise.
So just minimizing that movement.
Right. And for some women, it might be helpful to wear a bra even at night.
Okay.
Yeah.
What about medications? What are some of the go-to options for mild to moderate mastalgia?
So for mild to moderate pain, I usually start with simple things like over-the-counter pain relievers, like ibuprofen or acetaminophen. And then there are some dietary supplements that might be helpful. So Bailey and Love mentions flaxseed, which is rich in omega-3 fatty acids, and they recommend a dose of about 30 grams per day.
So just incorporating that into their diet?
Right. And then there's evening primrose oil, which is a source of gamma-linolenic acid. But the evidence for evening primrose oil is a little bit mixed.
So not quite as clear-cut.
Right. And then there are topical NSAIDs, so non-steroidal anti-inflammatory drugs that you can apply directly to the skin. And those can be helpful too, especially for localized pain.
Okay. And what about for more severe nostalgia when those first-line measures aren't enough?
Yeah, so for severe nostalgia, when the pain is really interfering with a woman's life, then we might consider using anti-estrogen medications. So tamoxifen is a common used one, and it's usually given at a low dose of 10 milligrams per day for 3 to 6 months.
So a relatively short course?
Yeah, and it can be very effective. Another option is ormeloxifene, which is given at a dose of 30 milligrams twice a week for 3 to 6 months. And ormeloxifene is interesting because it seems to be effective for both cyclical and non-cyclical nostalgia.
Oh, that's convenient. So you don't necessarily have to be sure about the classification to use it.
Exactly. And then there's danazol, which is another anti-estrogen
Yeah.
medication. But we have to be a little bit more careful with danazol because it can have some androgenic side effects, things like acne, hirsutism, voice changes.
So not quite as well tolerated.
Right. And then in really refractory cases, we might consider using a short course of LHRH agonists. These are medications that suppress the ovaries. So they basically put the woman into a temporary menopause.
So a more drastic measure. And what about those trigger point injections that we talked about earlier?
Yeah, so trigger point injections can be really helpful for non-cyclical nostalgia, especially when we can find a discrete trigger point. And what we do is we inject a combination of a corticosteroid and a local anesthetic directly into that trigger point.
So reducing inflammation and providing pain relief. Now, before we wrap up, I want to touch on nodular or lumpy breasts, which is something that we often see in association with nostalgia. How does the presence or absence of pain affect your management approach when you find nodularity?
Sure, so if a woman has nodularity and pain, then we'll manage the pain according to the principles that we've already talked about, trying to classify the pain as cyclical or non-cyclical and then treating it accordingly. But of course, we also need to evaluate the nodularity itself.
And what about when there's nodularity but no pain?
Yeah. So in those cases, we really have to be thorough in our evaluation. Bailey and Love calls this the triple assessment. So first, we do a careful breast exam to characterize the nodularity. Then we get imaging, usually a mammogram and an ultrasound. And then if there's anything suspicious on the exam or the imaging, we'll do a biopsy.
So it's really important to rule out any malignancy in those cases. And there's a scale that we can use to grade the degree of nodularity, right?
Yes, there is. It's called the Lucknow-Cardiff Nodularity Scale. And it goes from 0 to 4, with 0 being a normal breast and 4 being severe nodularity.
So that can be helpful for documenting our findings and tracking any changes over time. And what about treatment for nodularity?
Well, if the triple assessment is negative, meaning that we haven't found any evidence of malignancy, then reassurance is key. But for women who are having symptoms from the nodularity, even if it's benign, we can sometimes offer treatment. So antiestrogen medications like tamoxifen or ormeloxifene can actually help to reduce nodularity.
Interesting. So they can have a dual benefit there, helping with both the pain and the nodularity.
Exactly.
Well, this has been a fantastic deep dive into nostalgia and nodular breast changes. And it's really highlighted the importance of a careful, systematic approach to these common presentations. We've covered so much ground today, from the different types of nostalgia and their potential causes to the diagnostic workup and the various treatment options available.
Absolutely. And I think the key takeaway is that we need to be thorough in our assessment. We need to listen carefully to our patients, and we need to tailor our management to their individual needs.
Thank you for listening to our podcast. See you in the next episode.